Hi, I'm Dr. Bhargava. In this video, I will be sharing 20 cases with teaching findings. This is our first patient. The finding is incidental. On their CT of the abdomen and pelvis, we find that the aorta is heavily calcified, and there is a near complete occlusion of the lumen just distal to the origin of the renal arteries. Now, vasculature is frequently a blind spot for a lot of readers, especially trainees, and so make sure you pay special attention to the vasculature and pick up such incidental findings. This is our second patient. We are looking at a single image from an esophagogram showing a finding right here. So this is the hiatal hernia and a circumferential narrowing right here, which is consistent with a Schatzki ring. Our next patient shows classical findings of an esophageal web arising from the anterior wall on a modified barium swallow study. Here's our next patient. They underwent a CT of the chest, and we see a loculated pneumothorax right here in the lung windows. The pleura on both sides is thickened, and there are probably some debris inside. And on this axial image, we also find that there is an airway which is opening into this pleural space. And so this finding is consistent with the bronchopleural fistula. And even if this loculated pneumothorax is drained, it cannot resolve unless the bronchopleural fistula is treated, because air will leak through this airway into the pleural space, and so the treatment of this condition is surgical. This is our next patient, and we are looking at two coronal images, one from the CT scan on the left and one from the MRI showing the T2 weighted image. And this patient has a type 1 choledochal cyst. So here I'll show on the MR left-sided and right-sided bile ducts coming together to form the CBD. CBD shows marked dilatation as it goes towards the ampulla, and here we can see on the CT better that the caliber is normal at the ampulla. We also see a gallbladder which is opening into this dilated CBD. So this is a great example of a type 1 choledochal cyst. Next patient presented with menorrhagia, and we're looking at multiple images from the MR of the pelvis. The T2 weighted images in all three projections are on the top, showing that the endometrial cavity is occupied by this T2 hypointense focus. And this focus shows enhancement and no restricted diffusion on DWI and ADC images. Putting everything together, this is a polypoid or a submucosal fibroid. This next patient presented with signs and symptoms of bowel obstruction. They have a percutaneous jejunostomy. We see the part outside the patient. We see the bulb inside the jejunal loop. We see that the stomach is markedly distended, and we see some proximal dilated small bowel loops. And so the balloon or the bulb of this percutaneous jejunostomy catheter was causing obstruction. We see here that the bowel loop is closely opposed to this balloon. And so the cause of small bowel obstruction in this patient was the jejunostomy balloon. This is our next patient, a young female who presented with pelvic and perineal pain, and their CT scan shows this hypodensity in the left side of the perineum, and this has thick enhancing wall and also surrounding fat stranding. It's located inferior and posterior to the inferior border of the pubic symphysis in relation to the left vaginal wall. So this finding is an infected Bartholin gland cyst. Here's our next patient. They presented with lower GI bleed, or they were passing bright red blood per rectum, and a multi-phase CT was performed to localize the source of bleeding. So we have non-con arterial, and more delayed images from the CT scan showing the descending colon with contrast extravasation, and on more delayed images, the contrast dissipates in the lumen of the bowel. And if you pay attention, you'll find that this is a diverticular bleed because there is a diverticulum where this contrast extravasation is happening. And so this patient was treated for a diverticular bleed. Findings of contrast extravasation on a multiphase CT can be very subtle, and so we want to pay attention to the bowel loops, look at all the phases carefully to pick up subtle bleeding like in this patient. This is our next patient, and the finding here is incidental. Look at the stomach, and arising from the stomach and protruding posteriorly is this focus, also seen here on the coronal image and also on the sagittal image. And so the air fluid level gives away the diagnosis of a gastric diverticulum. And so a gastric diverticulum is frequently seen in the region of the adrenal and can be confused with an adrenal pathology. Our next patient had a suprapubic cystostomy catheter that we see here on the axial image. We see that the urinary bladder wall is thickened, so there was probably some kind of chronic outlet obstruction because of which a cystostomy catheter was placed. The tip of the catheter went inside the UVJ and is protruding into the distal part of the ureter as seen here, and also seen here on the coronal image and also on the sagittal image. And this, interestingly enough, this catheter is now occluding the UVJ, leading to right-sided hydronephrosis and probably ascending infection because we see a lot of perinephric fat stranding. We see same finding here of hydronephrosis and perinephric fat stranding. Compare it to the other side, which is a normal kidney. And so the CT was acquired without contrast because they presented with flank pain, and a CT renal stone protocol was performed, which is always done without contrast to look for hyperdense renal stones. This is our next patient. They presented with with signs and symptoms of obstruction, and their CT scan shows that they've had prior hernia repair, and then they have a recurrent large hernia that contains bowel loops, also seen here on this coronal image and the sagittal image. The hernia contains part of the distal bowel. We see signs of obstruction, dilated small bowel loops here. This is the part where the small bowel loop is going into the hernia, and then we see the proximal large bowel and also a portion of the appendix inside the hernia. And so this patient was obstructed with the transition point at the site of entry of small bowel into this large abdominal wall hernia. This patient recently had a renal biopsy, and they presented with abdominal pain. CT scan shows that there is a large density abutting the right kidney. And here is the kidney, which looks like it's been pushed forwards in this direction because of this hematoma. And so they have a subcapsular hematoma with internal focus of contrast extravasation suggesting active bleeding. And so if the perirenal hematoma or a hematoma which is abutting the kidney pushes the kidney, it's more likely to be a subcapsular hematoma rather than a perinephric hematoma. And whenever there is a hematoma, we want to look for contrast extravasation and make the diagnosis of active bleeding, raise the concern that this patient needs to be treated immediately by either surgery or interventional radiology. This patient had a pelvic ultrasound, and we're looking at 3 images. The one on the top left is labeled right ovary long axis view, which shows a anechoic focus with a cyst inside a cyst appearance in the right ovary. We see the same finding in the transaxial view, a cyst and another cyst inside. And here we are measuring this anechoic focus 3.5 by 2.8 cm, and this finding of a cyst and another cyst inside is seen just before ovulation, and this is called cumulus oophorus, and so it's a benign finding. We should recognize it and say that this is a developing follicle. And if you scan this patient again in the next cycle, you'll probably not see it. So it's important to recognize this physiologic finding and not confuse it with pathology. This patient's chest X-ray shows a cardiac device with two leads, one in the right atrium and the other in the right ventricle. And this patient underwent a CT of the chest, and on the CT axial image in the bone windows, we find these two leads in the SVC, also seen here on the coronal image, and around the lead there is a hypodensity. And so this is an incidental finding which is called a fibrin sheath. This can lead to development of a thrombus, pulmonary embolism, and catheter not functioning. So it's important to recognize this, and if they become symptomatic, treat this. Here's our next patient. We're looking at axial and coronal CT images showing an IVC filter. One of the struts of the IVC filter has penetrated the aorta, and overlying that we see a soft plaque or a thrombus. This can become an embolus, and so this needs to be treated. The treatment would be to carefully remove the IVC without further injury to the aorta. This is our next patient. They presented with history of trauma. On the coronal CT chest image, we find a rib fracture, probably more rib fractures not captured in the single image. The interesting finding is that they had mesenteric hematoma, an ill-defined density seen in the mesenteric fat. Here is another focus of mesenteric hematoma, and then a follow-up CT performed a few days later showed resolution of these post-traumatic findings. And so the most common organ to be injured in a trauma patient is spleen. The second most commonly injured organ in trauma patients is the liver. But remember to look for signs of injury in other organs, such as the mesentery or kidneys, or signs such as the seatbelt sign, which is seen as fat stranding in the subcutaneous anterior abdominal wall, because they can exist by themselves without injury to the spleen or the liver. Here's our next patient, a young male presenting with a symptom of passing bloody discharge through the umbilicus. On the CT scan, we find that there is a small abscess in the umbilicus. And so here is another subtle finding which can be missed if attention to the reason for the scan is not paid. And so always remember to look for why the scan is performed before starting to review the images. This next patient presented with right upper quadrant pain, and we see that the gallbladder is distended. They have these dependent hyperdense stones in the gallbladder. Although they don't have gallbladder wall thickening or pericholecystic fluid or fat stranding, look at the liver on this coronal image adjacent to the gallbladder. It shows hyperemia, and this is a good sign to suggest that they have acute cholecystitis. One of the stones is occluding the cystic duct, and because of that they have acute cholecystitis, and they're presenting with right upper quadrant pain. What I also do in such situations is look at their labs in the patient's medical records or the hospital EMR, and then frequently they will have elevated white cell count, which confirms that there is an infectious or inflammatory pathology in their abdomen and pelvis. This next patient also presented with trauma, and on this single axial image, we find that there are several rib fractures. And so frequently there are multiple ribs that are broken at more than one level. And in this situation, we should raise the suspicion for flail chest. Here is a graphic showing what is flail chest. So we can see that 3 ribs are broken here, and the same 3 ribs are also broken here, isolating this piece of chest wall, which moves inside at the time of inspiration and usually moves outside when the patient is in the stage of expiration. And so it's a clinical diagnosis, but when we see this radiologic finding of multiple ribs broken at multiple levels, we should raise the suspicion that the patient may have a flail chest. Thank you for watching.